So if it is your mother, her mother's mother, and her mother's mother's mother, it carries a higher risk in terms of your overall chance of developing breast cancer. Dimpling of the skin. Okay, so that's exactly what a dimple is. It's the skin being pulled in by this breast cancer.
Been there, done that, works like a bomb. Hi guys, and welcome back to another episode of ziRight Girls. I'm your host, Dr. Thalia Isaacs, and today Dr. Masina is not with us because she's in theatre delivering babies. We have a very special guest with us today. This is Dr. Bronwyn Boesack, who is a general surgeon. She's a lecturer at NMMU, and she's a biner like me. So this episode we're delving into breast cancer, as October is Breast Cancer Awareness Month. So we're going to take you through everything that you should know about breast health. Okay, so Bronwyn, can you tell us about how common breast cancer is worldwide and in South Africa?
Okay, so in South Africa, our statistics are a bit skewed. It's quoted to be about 1 in 27, 28 females that are affected with breast cancer in South Africa.
So that's like 1 in my son's class, because currently there are about 25 kids in his preschool class. So one of those girls in the preschool class, to put it into context.
That's correct. If we look at worldwide, if we look at places like Europe or Great Britain, their numbers are actually staggeringly higher, with 1 in 13 quoted as being the highest statistics.
So again, just to put that into context, that is 1 in the legal amount of people in a taxi.
Correct.
Okay.
So potentially every taxi ride has one woman with breast cancer in it.
Oh my soul. So like, what do we do to screen for breast cancer?
Okay, so clinically or by yourself, you can do self-examination of your breasts, and we could maybe delve into that a little bit. But in terms of what we doctors do is we screen with mammography, or commonly known as mammogram.
Okay, cool. So just so that people out there know, I'm a gynecologist. Bronwyn, you a general surgeon. My field of expertise is from the belly button down, basically from the belly button to the skin between your vagina and the anus. That's the realm of a gynecologist. We also do breast examinations, and we assist with screening for breast cancer, and we do mammograms. And then I will be referring to you because you will manage the breast further. But the breast is not my forte, right? I don't know how to operate on a breast. That's where Bronwyn comes in. So, okay, cool. So can you just explain to me the difference? Because I get very confused, right? Who gets ultrasounds and who gets mammograms?
So that's a very common mistake that we find that doctors and patients make, is who to screen with what. And actually the radiologists are the ones that are guided or that make the final decision. Breasts undergo changes as woman ages.
Yeah.
So any woman who's younger than the age of 40 tend to have denser breasts, i.e. breast tissue still within their breast. When you go over the age of 40, it becomes more fat.
Okay.
And that makes it suitable to be compressed by a mammogram for us to see pathology.
Okay.
The denser the breast, the less likely you are to see problems.
Okay.
Hence, then you do ultrasound or MRI or a special investigation that we call CT tomography.
Okay, cool. And so every woman should have breast screening from what age?
So currently the South African Radiology Association says from the age of 40. However, in my practice, I advise women who have a first degree relative who's had breast cancer to start 10 years younger than when their relative was diagnosed.
Okay. So again, for our listeners and our viewers outside there, to put it into context, for argument's sake, let's say I have a first degree relative, that's your mother, or your sister, and let's say mom got diagnosed at the age of 40, then I should start my screening at the age of 30.
Correct.
Okay. And then, because it's 10 years before my mom, and obviously like before the age of 40, because at the age of 40, I would start screening as in the general population.
That's correct.
Okay, cool. And then I would have either ultrasound depending on my breast density or a mammogram.
Yes.
And that will be based on what the radiologist decides.
That's correct. So if they do an ultrasound and they see that they do not see anything what's too technically difficult, they would then recommend an MRI. Okay. Most importantly, it's just to remember that you screen like for like.
Okay.
So for example, what that means is if you have an MRI last year, you should have an MRI this year.
Okay.
So that you can compare.
You don't chop and change.
You don't chop and change. There's no point in having had an ultrasound last year and this year then you can't draw conclusions effectively.
Okay. Does it matter, like, if my grandmother had breast cancer? Because now it's not a first-degree relative, it's further.
It does. So family history of breast cancer carries a significant risk factor, especially female relatives, and especially if it's seen within the pedigree. So if it is your mother, her mother's mother, and her mother's mother's mother, it carries a higher risk in terms of your overall chance of developing breast cancer.
Okay. Does the rule still apply then, still 10 years before onset?
So the rule still would apply. So if we see that there seems to be a genetic pedigree within that family, then that's the time where one starts having discussions about genetic testing.
Okay. So Bronwyn, like, another question that I had is when would you stop screening for breast cancer? Because like with us, with pap smears, we stop screening at the age of 65 if you've had 3 normal pap smears in the preceding 15 years. So when do you stop screening for breast cancer? Because I can't imagine like a 92-year-old lady coming to see me and she's got a broken hip and a pneumonia, and now I'm like, and by the way, let's just make sure you don't have breast cancer as well. When would you stop screening for breast cancer?
So we usually stop screening for breast cancer at the age of 70.
Okay.
If we use age as a pure cutoff. However, after 70, we individualize it.
Okay.
So if someone really has a significant risk, we would consider continuing for an infinite period. Or if someone is completely fine, we would just say no. Self-examination from here on inwards and come back and see us if there's any problem.
Okay, so on that, let's talk about self-examination for a little bit. Okay, so when and how do you do self-examination? So we know that, you know, there's breast tenderness during certain periods of your menstrual cycle. Are you meant to do it at a specific point in your menstrual cycle? Do you choose like a static date, like the 1st of the month or the 30th of the month? And then also, can you just tell us what I'm looking for? Because, you know, we can feel our boobs, but if I don't know what I'm trying to feel, like, then I might miss it. So how and what am I looking for and when?
So I think most importantly, it would be post your cycle if you are still perimenopausal or premenopausal as a woman. And I think for a postmenopausal woman who no longer has a cycle, she can pick a day or a date that is convenient and just make sure that it happens on a monthly basis.
Yeah.
It's most effectively if you continuously examine your own breasts to kind of know, okay, these are my breasts, this is normal, and have a feel for them. So firstly, you start off by looking at your breasts in the mirror. So you'd be completely topless in front of the mirror. You look at the shape. So yes, all women have different left and right breasts. That's not an abnormality.
Yeah, there's always one that's a little bit bigger and a little bit higher.
Correct. There's always one nipple that's slightly to the left and to the right, especially if you've breastfed your babies.
True.
And then asymmetry is one of the big signs that we look out for. So this means a major change between left and right. So we are blessed that we have 2 sides that we can compare left and right. So we start looking for any changes between left and right.
Okay.
Obvious ones is dimpling of the skin.
Okay.
Okay, so That's exactly what a dimple is. It's the skin being pulled in by this breast cancer. Other skin changes, such as what is called orange peel skin, pot orange.
This was not planned, guys. This is just like my normal kitchen, but yes. Orange peel skin or pot orange is when it has these this looks like a lemon peel skin or an orange peel skin. Okay.
Yes. So it just looks more porous and the pores of your skin is just more enlarged with a little bit of redness as well.
Okay.
Those are the major changes you would see or appreciate in the skin. And then the obvious one is a lump.
Okay.
Feeling a lump, feeling a hard or a rubbery or a firm mass within your breast is the ultimate sign or that you would feel.
Okay, cool. All right. So, Bronwyn, you want to take us through how to examine the breast? So, you spoke about we're looking for changes and feeling for lumps. Is there anything else?
So, when you examine your own breast, it's important that you do it when you are comfortable. So, either in your bedroom or in the shower works best. And you have to feel the entire breast. So I normally tell my patients, start from the nipple outwards in a circular fashion by feeling clockwise, anti-clockwise, it doesn't matter. Some people prefer examining with lines. So then I say, well, use the numbers on the clock.
Okay.
So start at 12 o'clock and work your way around, making straight lines. But most importantly, what people don't realize is that we have something called the tail of the breast.
Yes, yes.
So the tail of the breast actually extends up from the chest wall into your armpit, or as we call it, into your axilla. And that also has to be palpated or assessed during this examination. So as much as we focus on the face value, it's important to elevate your arm and examine in your armpit as well.
Okay. So, Bronwyn, you touched very mildly on genetics and risk factors for breast cancer. Can you tell us a little bit more on how genetics plays a role in breast cancer? I know some of our listeners might have heard of the word BRCA genes. What does that mean, and what for risk and for screening?
So, first and foremost, the biggest risk factor for developing breast cancer is being female.
Okay.
So, males also do get breast cancer, but it's overwhelmingly more common in females.
Yeah.
Secondly, the older you become, the higher your risk also becomes for breast cancer.
Okay.
And then there are other factors. So a big contributing factor, and maybe we'll just take a bit of time explaining this, is what people call an unopposed estrogen window.
Okay, yes.
So in simple terms, if you have your period very young and therefore you have your period for very long until you are 65 plus, that is many years of exposure to estrogen and cyclical changes.
Yep.
The longer you have that, the more your breast shed and the more your breast also change during those cycles. More cells that need to be generated, more likely mistakes are made, higher chance of a cancer forming.
Yeah.
In simple terms. So your other question about BRCA. So BRCA is a genetic mutation in a tumor suppressor gene, and it's been found in breast cancer and ovarian cancer, as you would be well aware of. Now, it's a very contentious issue because who do you test? Should everyone be tested for BRCA? The answer is no.
No.
High risk individuals, and who those are people that are younger than 40 who have a breast cancer, or someone who has bilateral breast cancers. That is a high risk of having a tumor suppressor mutation, i.e. BRCA.
Okay. And then this BRCA, I would assume, gets passed down through your lineage.
Yes,
and then it
it
makes
does.
your what do you call it? Your kids, the Afrikaans word's in my head, but I can't get to the English word. I'm not even Afrikaans first language, but it will then, obviously, you have a higher chance of then carrying this down to your kids and their kids and so forth and so forth. Okay. So if I've tested for BRCA and I've got daughters what would you advise me if I sat in front of you as your client?
So usually the companies that do the testing, if the index patient tests positive, then all of their female first degree relatives are tested as sort of free of charge or underneath that test.
Okay.
It does not mean that if you are BRCA positive, automatically your daughter will be BRCA positive. It's not autosomal dominant.
Okay. Okay, so autosomal dominant is like a 1 in 2.
Correct.
So you have a 50% chance. Okay, cool. Then I just wanted to talk to you about what do we do for women after they've, been treated for breast cancer. So again, like we as the gynecologists, we will then start seeing patients, obviously, for their annual pap smears and their annual, transvaginal sonars, and we're doing screening. And then this lady maybe had her breast cancer treated when she was 50. Now it's like presenting to us with menopausal symptoms. How do hormones and hormone replacement therapy affect treatment of breast cancer?
So, hormone replacement therapy is bad because, again, it
for breast cancer.
For breast cancer.
Let's just put in that caveat. Hormone replacement therapy is bad for breast cancer. Not hormone replacement therapy is bad. Okay, continue.
Okay, so in breast cancer and breast cancer survival, hormone replacement therapy is a no-no.
Yes.
Because it brings back that estrogen that we just spoke about earlier. Yeah. Also, in the management of breast cancer, we sometimes give patients hormonal therapy that actually blocks the effects of estrogen. So it would be very counterintuitive if we give them a blocker and the gynae gives them the estrogen.
Yeah.
So it is important that we have this bilateral or MDT approach to this patient in order to prevent recurrence.
So MDT stands for multidisciplinary team, which just means a multitude of different specialities working together for the common goal of that particular patient. So in a breast cancer patient, it would be a bilateral conversation between a gynecologist and a surgeon. So what we normally would do is, if you are a breast cancer survivor and you're having like hectic menopausal symptoms, vasomotor symptoms, so that's like your hot flashes, your mood swings, not really mood swings, but your hot flashes and your dry vagina, then we use antidepressants instead of hormonal therapy. Obviously, all drugs have side effects, but we obviously want to choose the one that's safest for you. So there is treatment for your menopausal symptoms, it just won't be hormone replacement therapy.
I also think, just on that note, I will issue a word of caution that the menopausal symptoms that is caused by our drugs or this hormonal therapy that we are talking about is much more dramatic than if you had natural standard menopause. It's basically you go from being normal to menopausal the next day.
So that's for a number of reasons. That's a number of reasons, right? So chemotherapy and the drugs that you guys use for chemotherapy in breast cancer is toxic to ovaries. So they basically give you a chemically induced menopause. So it's like, it is radical.
Menopause on steroids.
And then in some instances, like in your BRCA patients especially, you might be having conversations with your general surgeon and your gynecologist where they want to do what we call risk reduction surgery. So that's where your surgeon might, or your gynecologist might offer you a removal of your ovaries so that we remove that estrogen in order to protect you from progression of your disease or recurrence of your disease. And that, again, surgical removal of your ovaries causes menopause like that, whereas in a natural menopause, we normally say that perimenopausal part, we call it menopause when you haven't had your period for a year. So that's like a year that you've gotten time to get used to the hot flashes, whereas if it's chemotherapy or surgery, it's instant. So it can be quite dramatic. But never fear, we are here. We will help you through it. Oh, Bronwyn, it's always so nice to be in your company. But just before we wrap up, I just have one more question for the audience, right? So this is for our pregnant moms and our breastfeeding moms, right? So breast abscesses and mastitis. So if a mom gets a breast abscess, and she comes in through trauma, or she goes through a GP, or however she gets to you, she's got an abscess now and it needs incision and drainage, does she have to stop breastfeeding?
So let me just first correct you. We don't IND uncomplicated breast abscess in women that are breastfeeding, because that increases the chance of forming a fistula.
Yeah.
So that means that the hole you've made doesn't heal, and every time this poor woman is trying to feed, breast milk is escaping through this hole that you've made, and that's a terrible situation. So we aspirate it to dry using a needle.
Okay.
Does she need to stop breastfeeding? The answer is no.
Okay.
So we give baby safe antibiotics, so she can continue feeding on the other side, which is not affected, and express the milk on the affected side to help resolve her symptoms.
Okay.
And then once the inflammation and the redness and the pain and the cracked nipples and everything else that goes with a breast abscess has subsided, then she can restart her breastfeeding journey on that side safely.
Okay. And then just for anyone who is breastfeeding, who's had a breast abscess, or if you're pregnant and you're going to breastfeed, the tips and the tricks are, you need to empty your breast regularly, because what causes breast abscesses is little knots of milk that get stuck in the duct, and then you have a backup of this milk. And then obviously, like water that stagnates, bacteria settles in and then it causes an infection, and so on. So regular emptying of your breasts will prevent that from happening. If you have engorged breasts, so this is not an infection, it's just full breasts, then you can do either cold compresses or warm compresses, so a warm cloth or a warm towel on your breast, or you can stand in the shower, let the hot water run over you, and then milk that milk out. Also, always wear a bra, right? Your breasts are going to expand to its limit, and so the bra sort of holds those boobs in place so that it doesn't expand further than that. Cabbage leaves. What's your take on cabbage leaves?
It works. It's a cold compress. It's soothing. Go for it.
The only thing I will say is probably don't leave it in for longer than 20 minutes at a time, because it can also lead to drying up of your milk. But been there, done that, works like a bomb. You can ask Mr. Delivery, 10 o'clock at night, please bring me cabbage leaves. Right, Bronwyn, it was so cool to have you, and thank you for coming all the way from PE, my fellow Gabwegi.
Cheers, friend. It was good having a chat with you.
So there you have it, guys. Everything that you need to know about breast cancer awareness and your breast health. Remember that you should do self-examinations at least once a month, and after your menstrual cycle, if you are still menstruating. Otherwise, if you're menopausal, maybe do it before the debit orders go off. If you suspect that you're high risk, please consult with a general surgeon so that you can have your risk stratified and a management plan put in place for you. The general screening for breast cancer in the general population, so that means you have no family history of breast cancer, is at the age of 40 and above. And if you have a first degree relative, that is your mom or your sister, who has had a breast cancer, you start your screening 10 years earlier than the age of diagnosis in that person. So I hope that until we meet again,
ziRight.